Ria.
A very good evening to all. I welcome you for the ISA online teaching program. I am Dr. Ria Agarwal, working as senior resident at Dr. Ram Manohar Lohia Hospital, Lucknow, and I will be your coordinator for the evening. I would like to introduce the other coordinator, Dr. Shrutika Ved, also working as senior resident at Sardar Vallabhbhai Patel Institute of Medical Science and Research, Ahmedabad. Today's topic of case discussion is anesthesia for patient with hypertension posted for laparoscopic cholecystectomy. Before we proceed further, we will invoke the blessings of Ma Saraswati. I now welcome our Honorary Secretary, ISA, Dr. Professor Sukhminder Bajwa Sir, and would request him to say a few words.
Thank you, Ria. I think this class topic is very common throughout the country. You go from north to south, east to west. You will always encounter these cases, commonly posted for the surgical intervention in your operation theater. And invariably, you find comorbidity in these cases many times, like hypertension, diabetes, and other. And most common is the hypertension. And whenever these patients, when you put on bring the patient on the table, whatever the BP you must have recorded outside, it's almost, become 1.5 times on the table. There become the challenge, and you will be seeking how this thing has happened. This is a controlled hypertension, and suddenly you are encountering almost 170, 110, 120 BP now. How to go about it? That's the most distressing part. You are always in dilemma in dealing with these patients because uncontrolled hypertension, just for a small elective case of lap chole, you may be ending up with some complications. So there are many things associated with such cases, and I think none other better than Dr. Munisha and Dr. Amit. Dr. Munisha has already visited this hospital, Gyansagar. She came long back, almost 8, 9 years back. Yeah, I remember. More than that, maybe 10 years back. So it's almost after a decade. We are going live together on somewhere. And Amit is known to almost everyone. Their CVs will be read by our class coordinators. So rather than wasting time, I think, Ria, you should start the proceedings further, or Shrutika also. Please.
Yes, sir. Sure, sir. Thank you for those kind words. And good evening to one and all who have joined the ISA National PG online class today. I am Dr. Shrutika Paragved, a senior resident at Srimati NHL Municipal Medical College and SVP Hospital, Ahmedabad. Today, I'm here to introduce our esteemed faculties, Dr. Munisha Agarwal, ma'am, and Dr. Amit Kohli, sir. Welcome, sir, and welcome, ma'am. I would just like to go over their CVs. Dr. Monisha ma'am, she is the director and director professor and head at MAMC and LNH. She has been a nodal in charge of COVID ICUs. She has received the FICCI Healthcare Excellence Award for COVID-19. She has received Corona Warrior Award by the DMA. She has been recognized as the Mamco's Teacher Award for recognition of 25 years of service as a faculty, and she has been the clinical director of anesthesia for the Commonwealth Games of 2010. Her areas of interest span from fibroscopy and difficult airway management to BLS and ACLS, pediatric anesthesia, anesthesia for bariatric surgery, teaching and training, and in medical oxygen infrastructure and logistics management. Our other faculty joining today is Dr. Amit Kohli sir. He is a professor at Maulana Azad Medical College with a teaching experience of spanning over 18 years. His specialty interest lies in difficult airway management, critical care achievements. His Hello, am I audible?
Yeah, audible, Shrutika.
Yes. His achievements. The first and foremost being he is the honorary secretary right now of ISA Delhi for the term of 2023 to 2026. He was the executive member of RSACP for ISA Delhi from 2020 to 2023. He has been a member of Delhi NCT Oxygen Cell. He is a course director of Advanced Airways Skills Workshop, an examiner of MD, NB, NMC, and an NBSSN. His awards include the ISA National President Appreciation Award of 2021, the ISA National Proficiency Award for 2021, and the ISA Delhi President Appreciation Award for 2022 and 2023. None of the least is publications. 42 out of the 60 have been PubMed indexed, and he is an editor of 2 books. I welcome sir and ma'am to today's class. And now, before I request our faculties to take over the class, I would like to make a small announcement. Everyone joined is requested to kindly keep the microphone muted and video turned off. You can type all your queries in the chat box after writing your introduction. All the queries will be addressed at the end of the session. Thank you so much. Over to you, Dr. Manisha ma'am and Amit sir.
Thank you, Shrutika, sorry. Let me introduce to you people, our postgraduates. They are both final year exam going postgraduates. One is Dr. Megha and other is Dr. Laltendu Das. Are you here, both of you?
Yes, ma'am.
So, Amit, shall we start?
Yes, ma'am. Yes, please.
Okay. So, who's going to, let's start with the history of your patient, Das.
Yes, ma'am. Ma'am, am I audible, ma'am?
Yeah, you
Yeah,
are.
yeah. Go ahead, please.
We'll be presenting a patient for laparoscopic cholecystectomy as a case-based discussion. Mrs. Sunita, a 42-year-old female, homemaker by profession.
Yeah,
presented by-
Laltendra, can you share your screen for the PPT? Share your screen.
Yes, sir.
Make it full. Fine. Go ahead.
Mrs. Sunita, a 42-year-old female, homemaker, presented to the hospital with the chief complaints of upper abdominal pain for the last 4 months and intermittent vomiting for the last 4 months. History of present illness. The pain was located in the right upper abdomen, sudden in onset, colicky in nature, and gradually increase in intensity, lasting for around 5 to 10 minutes. It was associated with burning sensation and vomiting. and was relieved with medications and aggravated with spicy meal. The vomiting was sudden in onset, episodic, and non-projectile. It was greenish in color and occasionally contained food particles. There was no yellowish discoloration of eyes or urine. There was no fever, no loss of appetite, no weight loss, no evening rise of temperature. No alteration of bowel and bladder habit were observed. No passage of black or clay-colored stools. No bleeding diathesis. No abdominal distension. There was no history of chest pain, no palpitation or shortness of breath. There was no history of stroke, transient ischemic attacks, syncope, dizziness, headache, or blurring of vision, or decreased urine output. There was no history of jaundice, tuberculosis, cough or runny nose, no history of blood transfusion, and the patient is a known case of hypertension since past 2 years on tab telmisartan 40 mg 40 mg once a day, and tablet amlodipine 5 mg once a day. Coming to the past history, the patient has no history of diabetes, coronary artery disease, thyroid disease, asthma, COPD, or seizures. She also does not have any history of any prior surgeries. The personal history: the patient studied till class 10, is a homemaker, consumes a mixed Indian diet with a total calorie intake of around 1980 kilocalories per day. There is no history of alcohol consumption or smoking. She has a normal bowel and bladder habit and a normal sleep pattern. She does not have any known allergies. The obstetric and gynec history: she has been married since 20 years, has 2 children via normal vaginal delivery. Her last menstrual period was on 31st May 2024 and she has a normal menstrual cycle. There are no other history of any similar or any other chronic illnesses in the family. The treatment history: she is on tablet amlodipine 5 mg once a day and tab telmisartan 40 mg once a day. She is compliant to her medication, and on workup of the patient by the surgery team, the ultrasound was done, where the ultrasound whole abdomen was done, which showed multiple calculi in the gallbladder, with the largest calculi in the gallbladder, with the largest stone measuring around 5 millimeter. Now Dr. Megha will present the examination findings.
Coming to the general examination of the patient, our patient is conscious and oriented to time, place, and person. Patient is sitting comfortably on the bed. Height of the patient measured was 157 centimeter, weight was 58 kgs, and the BMI was 23.5 kg per meter square. She is afebrile to touch. Pulse rate is 84 per minute, which is regular, normal in volume, and corrected. There was no radial or radiofemoral delay. The blood pressure was 110 by 70 millimeters of mercury in left arm in sitting position. Respiratory rate was 12 per minute, regular, abdominal thoracic. Oxygen saturation was 98% on room air. There is no pallor, edema, cyanosis, clubbing, icterus, or lymphadenopathy. The jugular venous pressure was not raised. On airway examination, there is no obvious facial deformity. Bilateral nares are patent. Mouth opening shows interincisor gap of 4.5 centimeter, modified Malampatti class of 1, upper lip bite test of grade 1, thyromental distance of 7.5 centimeter, neck range of movement is full, free, and painless, normal dentation, and no loose tooth. Coming to the abdominal examination, on inspection, the abdomen is scaphoid and uniformly moving with respiration. Umbilicus is inverted and midway between xiphisternum and pubic symphysis. No visible scar, pigmentation, ulcer, venous prominences, swelling, and swelling was seen. On palpation, all the inspectory findings were confirmed. Normal temperature and soft on touch and non-tender. No palpable lump. No muscle guarding, pulsation, fluid thrill, or rebound tenderness. There was no hepatosphenomegaly. On percussion, there was tympanic note. The liver span was 12 centimeter. Upper border of liver was palpated at right fifth intercostal space along mid-clavicular line, while the lower border was at the right seventh intercostal space along the mid-axillary line and right intercostal space along the scapular line. Shifting dullness was absent. On auscultation, bowel sounds were heard. Respiratory examination. On inspection, bilateral chest was moving symmetrically with respiration. No obvious scars, pulsation, or distended vein seen. On palpation, inspectory findings were confirmed. Trachea midline, bilateral symmetric chest expansion. On percussion, resonant and bilateral lung fields. On auscultation, bilateral air entry was equal and normal vesicular breath sounds were heard with no added sounds. On cardiovascular examination, on inspection, no precordial bulge, visible pulsation, apical impulse not seen. On palpation, no parasternal heave, no thrills, apex beat localized at fourth intercostal space, lateral 1 centimeter lateral to the midclavicular line. On auscultation, first heart sound and second heart sounds were heard, no other sounds were heard. Nervous system examination, all higher mental functions were intact, all cranial nerves were normally functioning, build, tone, power, coordination of all the motor units are normal, all sensory functions and reflexes are intact, cerebellar and autonomic functions are normal, gait is normal, no trophic changes and no tender peripheral nerves were seen. This concludes our history and examination part for our patient.
So, Megha, based on your history and examination, what is your tentative diagnosis?
Based on history and examination, my differential diagnosis will be peptic ulcer disease, cholelithiasis, and chronic pancreatitis.
Okay. So, the patient was sent to the surgeons and they did the sonography, etc., and they have confirmed the diagnosis of gallstone disease.
Yes, ma'am.
So, let us assume that this patient is scheduled for laparoscopic cholecystectomy for this disease.
Yes.
All right.
Yes, ma'am.
So, we need to prepare the patient.
Yes, ma'am.
Yeah. Megha, can you tell us the complete diagnosis? This was your differentials. How will you tell the diagnosis to your examiner?
Yes, ma'am. Sunita, 42-year-old female with a known case of hypertension, present with history of right abdominal pain for the past 4 months, is a case of symptomatic cholelithiasis.
So your patient, Megha, is a case of symptomatic cholelithiasis, right?
Yes,
so
sir.
most likely your patient will be posted for cholecystectomy,
Yes.
right? This is there. So if your patient is planned for cholecystectomy, Megha, what all investigations would you like to do for the patient beforehand?
Sir, I would like to go for a complete blood count. I will ask for a liver function test, kidney function test, urine analysis, and 12-lead ECG and a chest X-ray for my patient.
Okay, so you are getting ECG also in your patient and chest X-ray also in your patient. So
Yes.
do you routinely do these two investigations in all your patients who are posted for surgery?
No, sir.
You said so. So do you routinely do these two investigations, chest X-ray and ECG, in all your
No,
patients
sir.
subjected for surgery?
No, sir. Not for all patients, ECG
So
and
what
chest.
makes you to do? Are there any recommendations or something? What makes you to do in this case?
Yes, sir. According to American Society of Anesthesiology guideline, any patient who has the age of more than 40 years presenting for surgery should have a chest X-ray and ECG done.
Okay, or any other patient who is less than that and still you want to get it done?
Yes, sir. If there is any history of chest pain, any previous history of chest infections, in that cases we can get a chest X-ray done.
And
Okay, so basically the age.
also your patient is a known case of hypertension for
Hypertension,
past many years.
Yes, ma'am. And any
Very
previous
pertinent to do ECG as well as X-ray. All
Yes.
right.
So, Megha, I told about American Society of Anesthesiologists and this thing. So there is an article in our Indian Journal of Anesthesia also. Their Indian Society of Anesthesiologists have also come up with the PAC investigations. So all PGs should go through it, right? It's available on Indian Journal of Anesthesiology. So Megha, you were getting liver function tests also done?
Yes, sir.
So what is the relevance of getting this liver function tests done for an anesthesiologist in these patients?
So liver function test is usually done by the surgery team during the workup of this case. They usually want to rule out any obstructive pathology by seeing the total bilirubin. So it has so they rule out any obstructive pathology. So they get a liver function test done.
So supposedly the patient is coming to you in a PAC clinic and an LFT was there almost a week back.
Yes.
Was done and it was grossly okay. Some mild derangement of the liver enzymes, but grossly okay. So would you like to get it repeated before cholecystectomy?
No, sir.
There's no need if they're grossly normal.
Yes.
So the take home for all our postgraduates who are listening to us, the investigation should be pertaining to your case or pertaining history of the patient, right? In this particular case, we are just getting CBC done, and we are just getting liver function test, chest X-ray, ECG, as well as urine routine microscopy, and no more extra investigations if you don't have any justification to do the investigations.
So now, Das, tell us, your patient is apparently scheduled for laparoscopic cholecystectomy.
Yes, ma'am.
So why not an open cholecystectomy? What are the advantages patient has if he or she undergoes a laparoscopic surgery vis-a-vis an open surgery?
Yes, ma'am. Ma'am, laparoscopic cholecystectomy involves smaller incisions, smaller 5 mm or 10 mm incisions, which are given, muscle splitting incisions which are given. So the post-op pain will obviously be lesser as compared to a open cholecystectomy. Also, ma'am, the recovery in the post-op period in a patient of laparoscopic cholecystectomy will be better. The post-op analgesia requirement will be lesser. Ma'am, because of the usage of uh, uh, the post-op recovery will be better, ma'am. Also, because the cost that is involved to the patient overall will also decrease. The stress response that is associated with laparoscopy is far lesser as compared to open cholecystectomy. So that way also the patient will have better thing.
Mostly you can, I mean, these laparoscopic cholecystectomy done on the daycare basis.
Yes,
So
ma'am.
the hospital stay is reduced. The
Reduced, yes.
cost incurred by the
Patient
hospital
is
is also less. So those are the advantages of laparoscopic, but we must remember that even a laparoscopic procedure has its all disadvantages, and complications can occur during a laparoscopic procedure also. So when you are taking consent for a laparoscopic procedure, you should always explain and take consent for an open procedure also. At any time, if the surgeon faces some problem intraoperatively, whether from the anesthesia side or from the surgical side, he may go in for an open surgery. Okay. So, Megha, tell us what during your lap surgeries, what is the gas used? What should be the ideal gas?
Carbon dioxide gas is used for insufflation.
Okay, why carbon dioxide? Anything special about it?
Carbon dioxide does not support combustion. It is readily soluble in blood, and it can be rapidly eliminated by our lungs, and it is cost effective and easily available. So carbon dioxide is used for laparoscopic surgeries.
But as it has all these advantages, does it have any disadvantages also?
Yes, ma'am. It can cause diaphragmatic irritation, and it can cause pain in the post-op.
Pain where?
In the right shoulder tip pain. It can cause right shoulder tip pain.
Okay. What else?
Yes, ma'am. And there are.
Is it inert? Is carbon dioxide inert?
No, ma'am.
No. So it must be getting absorbed.
Yes, ma'am.
So what are the disadvantages of its absorption?
Leading to carbon dioxide absorption can cause vasodilation. It can increase our pulmonary vascular resistance. It can increase our cerebral blood flow, ma'am.
So it can lead to respiratory acidosis and
Yes,
all
ma'am.
problems associated with hypercarbia.
Yes.
So any other gases you know of which can be used for laparoscopic or have been mentioned in the literature?
Yes, ma'am. Apart from carbon dioxide, many other gases are used, which are oxygen, air, helium, argon, and nitrous oxide.
Okay, so any of these gases which are used, for example, argon, helium, the literature mentions, do you ever use them? Have you seen it being used?
Not in our institute, ma'am.
I don't think any other institute is also using. So why do you think it is not being used?
Because all these gases, ma'am, they support combustion, and plus they are not readily soluble in blood, and so there are chances if embolism happens, there are increased effect of those embolism, and plus they are gases like helium and argon are expensive, so they are not readily used.
So
And
that
they are
means,
and they also support combustion.
so that means then of all these gases, carbon dioxide fulfills the bill of an ideal gas used for laparoscopic surgeries.
Okay, so thus your patient is basically going for a laparoscopic cholecystectomy, right?
Yes, sir.
And it is an upper abdominal laparoscopy.
Yes,
So can you please tell me that what are the anesthetic considerations in this particular case?
Sir, the anesthetic considerations in this case would be due to three major considerations. That is due to the increased intra-abdominal pressure, due to the effect of the pneumoperitoneum, and the increased carbon dioxide, that is hypercarbia, and the position changes, sir.
Okay. Okay. So you mentioned the three things related to the laparoscopic cholecystectomy,
Yes, sir.
right? So both Megha and Das, your patient is certainly it's a gallbladder disease and coming to you for laparoscopic cholecystectomy, but don't forget that your patient is a hypertensive patient
sir.
also. Though today we are focusing mainly on laparoscopic part of in the particular session, but yes, whenever your examiner asks you, you should be telling the considerations in toto.
Okay.
Right? So you should be telling it something about hypertension in addition to this particular three things which you have mentioned about your laparoscopic procedure, upper abdominal laparoscopy. That makes your answer complete.
Yes.
To all the postgraduates who are listening to us today, this anesthetic considerations of laparoscopic cholecystectomy, your examiner can ask you in the Viva OC also, or that can be your theory question also. So as in laparoscopic cholecystectomy, you just divide it into three parts. Whenever you are answering your question, the considerations related to pneumoperitoneum, considerations related to increased intra-abdominal pressure, as well as position-related considerations. And lastly, you mentioned that your patient is a hypertensive patient also. So some considerations related to hypertension during anesthesia. That makes your answer complete. So thus you have mentioned about...
Amit, sorry, just to interrupt, I just wanted to mention for any case, when you are asked anesthetic considerations, it is good to divide your considerations under three heads. Considerations related to the surgical procedure. Okay, here we are doing laparoscopic cholecystectomy, and the subheadings will be as mentioned by Dr. Amit, these three. Okay, then considerations related to the patient characteristics, whether he is, a pediatric patient, geriatric patient, obstetric patient. Okay, she is a healthy adult female in your case. And third, considerations related to the comorbidities and its treatment the patient is on. Right, Amit? I think it is better if
yes,
we
absolutely,
divide.
ma'am.
We will
Absolutely,
not forget.
Yes, absolutely. They'll be, they'll not be forgetting it in any case. And at the same time, they'll be scoring high if they plate their answer properly. So coming to you, Das, that you mentioned regarding laparoscopic cholecystectomy that there are concerns related to pneumoperitoneum.
Yes.
So can you please tell me what are the systemic concerns or the systemic effects of creation of pneumoperitoneum?
Sir, pneumoperitoneum can have an adverse effect on multiple organ systems. In the respiratory system, it causes a cephalad shift of the diaphragm, thus decreasing the functional residual capacity. It causes a increased atelectasis of the basal zones of the lung. It increases the airway pressures, that is both the peak inspiratory pressures as well as the plateau pressures. And it also increases the VQ mismatch that may occur during the surgery. Sir, the hemodynamic considerations would be because the pneumoperitoneum created can compress the IVC and decrease the venous return to the heart, and that can cause a further decrease in the cardiac output. Also, it has been observed that the peripheral vascular resistance increases, as well as the systemic vascular resistance, as well as the pulmonary vascular resistance increases, thus increasing the afterload to the cardiac output noticed. This is when we look at the renal system, the renal blood flow is decreased, thus decreasing the glomerular filtration rate and the urine output. In cases of prolonged surgery, the urine output could be decreased. In the central nervous system, the blood flow to the central nervous system is decreased, as well as the blood flow to the central nervous system is increased, and that can cause an increase in intracranial pressure as well as an increase in intraocular pressure. So, sir, these are the effects.
Can
These
you
are mainly the
project
systemic
the
effects.
slide which you had made, Megha?
Yes.
So basically, when you are talking about the cardiovascular system, the two systems are important for an anesthesiologist, mainly, chiefly, that is cardiovascular system and the respiratory system, right? So cardiovascular system, thus you mainly mentioned that there is a decrease in the cardiac output, right? That is
Yes,
the
sir.
main concern which you have mentioned in this particular case,
Yes, sir.
right? So can you please tell me something about that? There is kind of a biphasic change in the cardiac output during laparoscopic cholecystectomy. What do you mean by this biphasic change?
Yes, sir. Sir, the biphasic response that is observed is initially there is an increase in cardiac output followed by a decrease, sustained decrease. The initial increase of the cardiac output is because of the splanchnic circulation emptying its blood into the central compartment, and that can cause a transient increase in the venous return and thus increase the cardiac output. But later on, as the pneumoperitoneum settles and compresses the IVC and decreases the venous return, the cardiac output further decreases. So initially it increases, a transient increase followed by a decrease.
So you said that this pneumoperitoneum settles. What do you mean by this pneumoperitoneum settles down?
Sir, the right word would not be using settle. The right word, as the when the pneumoperitoneum has been created and the compression of the IVC has occurred. After that, this thing cardiac venous
Yeah,
return.
so you mean to say that there will be some time in which the effects of the pneumoperitoneum remains there, and after that, transiently the effects will be normalized.
Yes, sir. Yes,
so that is the thing. So all the postgraduates, use of the words are very important. Your examiner can pick up your words, if you use some wrong words at the wrong place, right? That is particularly there. So can you please tell me that what is that particular time when you can expect that the cardiovascular changes usually due to the pneumoperitoneum starts settling down?
Sir, between 25 to 30 minutes post insufflation of carbon dioxide, the changes the hemodynamic changes begin to settle.
Usually not more than 15 to 20 minutes. 15 to 20 minutes is most of this thing literature says. Laparoscopic cholecystectomy, many surgeons can get it done in 30-35 minutes. That is the total time for the surgery, right? Isn't it? So important thing is the cardiovascular system is very important, as is rightly mentioned, right? That there is changes in the cardiac output in this thing, and as all the students can see it on the screen, that the effect of cardiovascular effect or the hemodynamic effects of laparoscopic surgery, right? That is mainly because of creation of pneumoperitoneum, as well as also due to the increase in the intra-abdominal pressure. Your venous return decreases, your SVR increases, and these are the two main factors which leads to decrease in your cardiac output. But yes, the decrease in cardiac output is transient. It settles down in initial 15 minutes of creation of a pneumoperitoneum, right? That is something which is important for you to know, that when you're mentioning the systemic effects of the pneumoperitoneum, right? So one thing you have said that this thing, you have heard that there may be some kind of an arrhythmias or hemodynamic fluctuations which may happen due to creation of pneumoperitoneum. Can you tell me something about that?
Sir, arrhythmias are usually observed at the beginning of creation of pneumoperitoneum. They have been observed. That the cause of arrhythmias that occur is because of the reflex vagal stimulation that occurs. Previously, it was being said that carbon dioxide is a cause of these arrhythmias, but it has been established that it is a reflex vagal stimulation that is responsible for the arrhythmias that occur.
Okay, so it's mainly, what you mean to say is that it is the arrhythmias which are happening, right? That is due to what? Due to increased intra-abdominal pressure?
Yes, sir. Intra-abdominal pressures and the peritoneal irritation that can cause a vagal stimulation, and further
arrhythmias can be seen in that particular thing during the initial 15 to 20 minutes when the creation of pneumoperitoneum is basically happening. So can you please tell me that what is the rate of insufflation and why this rate of insufflation is important for an anesthesiologist?
Sir, the rate of insufflations is usually during the creation of pneumoperitoneum, it is kept at around 4 to 6 liters per minute, and then it is decreased to 200 to 400 ml per minute, sir. Sir, it is important because during the creation of pneumoperitoneum, if we cause sudden increase in the pressures, that can cause about drastic consequences in the hemodynamic circulation as well as the respiratory parameters. So that is why we have to be careful about
this thing. This has to be gradual,
Yes,
you
sir.
say that has to be gradual increase in the in this. So how much should be the pressures, ideal pressures?
So the pressure should be maintained at around below 15 mmHg. Usually the insufflation pressures are between 10 to 12 mmHg, sir.
Okay, it should be kept less than 15 by anyhow,
Yes,
but it has to be ideally between 10 to
10
12,
to 12
millimeters
millimeter.
of mercury. But anyhow, the less than 15 millimeters of mercury, and it should not be then all cardiovascular changes and the respiratory changes starts increasing because of this pneumoperitoneum, right? This is there. And you also said there's some changes on the respiratory system. Again, this respiratory system is very important for anesthesiologist, right? So how this is affecting the respiratory system? Is it favorable? Is pneumoperitoneum favorable for respiration or not favorable?
No, sir. It causes a cephalad displacement of the diaphragm, so the thoracopulmonary compliance would decrease, sir. Also, sir, the pressures, the inspiratory, peak inspiratory as well as the plateau pressures would rise as pulmonary compliance would decrease. The VQ mismatch would occur. So these are the complications that could occur, sir.
So what can be the what do you think should be the percentage changes in the compliance and the FRC, if I may ask?
Sir, around 40%, 45% changes in the FRC as well as the compliance, thoracopulmonary compliances. Around almost nearing to 50%, sir. 50%.
Okay, so 30 to 40% approximately,
Sure.
right? Right.
Now we have talked about the effects of pneumoperitoneum, the effects of raised intra-abdominal pressure. So the third thing is the position of the patient. So Megha, what is the initial position of the patient when you create pneumoperitoneum?
Ma'am, pneumoperitoneum is created with patient in supine position.
Okay. Thereafter, what is the final position the surgeon wants to operate in?
Ma'am, the surgeon wants a position of reverse Trendelenburg with a right up position. Reverse Trendelenburg is head up position and right up.
Okay. So as an anesthetist, this position is favorable for you or it's not good?
Ma'am, this position, the hemodynamic changes are all aggravated. The hemodynamic changes due to pneumoperitoneum are all aggravated. And there is further decrease in venous return in this position, which will further decrease our cardiac output. Whereas it is favorable for our respiratory system because there is the capillary displacement of our diaphragm is decreased. So there is relatively increase in FRC, which can lead to a better VQ, lesser VQ mismatch and better oxygenation of blood.
So this venous stasis in the legs also promotes thromboembolism.
Thromboembolism.
So how do you, I understand that laparoscopic cholecystectomy is a very short procedure with trained surgeons. But in some laparoscopic surgeries which are of longer duration, this problem can be, of concern. So what can be done to remove this, problem, prevent this problem?
Yes,
what the surgeon can do?
Yes, surgeons usually apply pneumatic compression devices so that the venous pooling will decrease, the stasis will decrease, so the risk of thromboembolism decreases. These are particularly done in obese patients, ma'am, so in which the risk of thromboembolism is higher and prolonged duration of surgery.
All right. And another thing, as you said, in this position, head up and right up position, because the venous pooling is occurring and, the venous return is decreased. So as Das just said, that creation of pneumoperitoneum will eventually lead to a decrease in the cardiac output, isn't it?
Yes.
So your patient is hypertensive also, isn't it? So does it bother you?
Yes,
because this will further cause a decrease in cardiac output.
Yes.
Does it bother you, and how can you, prevent this, or how can you deal with this situation?
Yes, ma'am. Since my patient is hypertensive, he is already in a volume contracted state, and creation of pneumoperitoneum and further the positioning will ultimately decrease venous return to our patient, venous return. So to prevent these changes, we will ensure that our patient is adequately preloaded before the creation of pneumoperitoneum. So we will assess our volume status in a very crucial way and will adequately preload our patient to prevent these complications further.
So before the pneumoperitoneum is created by the surgeon, it is important that you have a euvolemic patient, especially if there are associated cardiac, problems like hypertension or any other low cardiac output state, valvular heart lesions like mitral stenosis, etc. Okay, so just by the way, what is the position preferred for gynecological laparoscopic surgeries?
Ma'am, in gynecological surgeries, surgeons prefer a Trendelenburg position, which is
So
a head
why is this difference?
because it gives a better exposure to a pelvic organs in Trendelenburg position.
Okay, so that's about the positioning of the patient.
So your patient thus is subjected for a laparoscopic cholecystectomy. So certainly in laparoscopic cholecystectomy, surgeons will insert the ports also.
Yes,
So why, as an anesthesiologist, it is important for you to note the port sites?
Sir, there are usually when they're inserting the port site, sir, if the stomach is not deflated and it is stomach is not deflated during the insertion of the trocar or during the insertion of the needle, there can be perforation of abdominal contents. Also, sir, during the insertion of the needle, it can directly injure a vessel and it could lead to a direct insufflation of carbon dioxide into the vessel itself. So, sir, we should be aware of those and keep in mind that those changes can occur.
So, and your patient is for upper abdominal laparoscopy, right? So port
sir,
may be
yes.
above the umbilicus also at
Yes, sir.
times, right? This is
Yes.
particularly there. So that if the pain at the port side will be there, so you'll be,
Yes, sir.
the patients will have difficulty in breathing later on. And so these are all the considerations we should be knowing. So knowing the port site is very important, but all sites, your surgeon is inserting the port. So it's not only the surgeon's part, your anesthesiologist should also be very much, looking into each and every surgical steps. So three things, thus you said about this particular laparoscopic thing. One is creation of pneumoperitoneum positioning, and third is intra-abdominal pressure. Can you please quickly tell me what are the effects of increased intra-abdominal pressure? As an anesthesiologist, why it's worrying you?
Sir, increased intra-abdominal pressure would cause a decrease in would cause a compression of the venous compression of the IVC again, and that would further again cause a decrease in venous return, causing a further decrease in cardiac output. Also, sir, this increased intra-abdominal pressure can cause a peritoneal irritation, and it can cause a increased sympathetic response, which can cause about a increase in mean arterial pressures and increase the afterload to the cardiac output. Sir, this can increase IAP, can also push upon the diaphragm, make it more cephalid, and decrease the thoracopulmonary compliance again, decrease the compliance, increase the airway pressures, and sir, also this can cause about if we have used the endobronchial tube here, it can also endotracheal tube if you have used, it can cause about endobronchial intubation also. The tube can be displaced. Also, the device, if you are using a LMA device, that also can be displaced, sir. So these are the changes that can occur here. The increase in intra-abdominal pressure can further cause a decrease in renal perfusion and a decreased GFR. Yes, sir. These are the
okay. So these are the systemic effects of the increased intra-abdominal pressure, right? That is particularly there. Right? So I really want to know that you told about that how much should be an ideal pressure. We should not exceed an pressure of around 10 to 12 millimeters of mercury. But a while back, you also said the rate of insufflation. Why the rate of insufflation? It will be bothersome for the surgeons. Why, as anesthesiologist, I'm more concerned about the rate of insufflation?
Sir, a rapid rate of insufflation would cause about a very sudden changes in hemodynamic parameters, and that can adversely affect the patient. So that is why we are worried about the rapid insufflation. We do not allow rapid insufflation.
So what is main worry? What may happen, with the rapid insufflation? More worried about cardiovascular system related effects?
Yes, sir.
So what may happen? If there is a rapid insufflation, what may happen to the patient?
Sir, there can be bradyarrhythmias that can occur because of the rapid insufflation, ranging from
chances of arrhythmias.
Yes, sir. Arrhythmias ranging from bradycardia to first degree, second degree heart blocks, and even asystole.
Okay. So bradyarrhythmias and and leading to the heart blocks, yeah, right, can be one of this thing. If there is a rate of insufflation is not it will be very rapid or something like that. So it has to be very gradual. The hemodynamic effect should not supersede in the beginning adverse hemodynamic effects, right? So there should be a time for the adjustment to the patient's systemic cardiovascular system. Right, this is there. So this is particularly important for in this particular thing. So we have covered. You're told about pneumoperitoneum, position-related effects, as well as the third thing, increased intra-abdominal pressure. At the same time, we have touched upon hypertension-related cardiovascular effects to make it a complete reply.
Okay, Das, you have talked so much about pneumoperitoneum, that it is causing such a lot of problems. So is there any way we can do away with this pneumoperitoneum and still do a keyhole surgery for the patient, especially patients who are, are having associated comorbidities, cardiac and other respiratory?
Ma'am,
Is there any other technique used by the
yes.
surgeons?
Yes, ma'am. Yes, ma'am. Ma'am, there is this technique called gasless laparoscopy, ma'am. In that, a ceiling fan retractor is used to hold up the abdominal wall, and that enables that increases the view and the operating space for the surgeon. Also, that will require a minimal level of insufflation required, but the amount of gas and the pressures and the insufflating rate will be obviously less than what we will be using in a plain pneumoperitoneum.
But yes, that is, but it is not a very popular technique because I think it is technically difficult. You need
Yes,
to
ma'am.
have a very expert surgeon. It takes longer to complete the surgery. So everything has an advantage or a disadvantage. Yeah. Gasless laparoscopy. Yeah.
So Megha, your patient is now a case of gallbladder disease who is now posted for laparoscopic cholecystectomy. So can you please tell me what are the pre-anesthetic advices to your patient? The patient is coming to you in a PAC clinic, right? Before that, let me ask you one more thing. That suppose patient has come to you in a pre-anesthetic clinic, right? And when you're doing the systemic examination and general physical examination, you find your patients, when you're taking a blood pressure, the patient's blood pressure is coming to be somewhere around, you can say, 140 by 96 millimeters of mercury, right? Would you like to go ahead with the surgery?
No, sir, I'll not like to go ahead with the surgery.
Why?
So, because since my patient is not well optimized for elective procedure like cholecystectomy, I like my patient I'll like my patient to review the doses for hypertension and get the blood pressure optimized within the normal range, and then like to proceed with the surgery.
Yes, very rightly said. It's an elective procedure, so blood pressure needs to be optimized. So, as per the latest guidelines, which latest guidelines you are following for, hypertension?
Yes, sir. So JNC 8.
JNC 8 is one which is, so all the students should be well versed with the JNC 8 classification for hypertension whenever you're dealing with such cases, right? This is there. So, what is your cutoff value for elective surgeries generally?
Sir, any blood pressure less than 140 by 90, we will go ahead with our surgery.
130/90.
Yes, 130/90 millimeters of mercury.
Millimeters of mercury. All the students should be completely staying when speaking. Whenever somebody asks you blood pressure, it's just not 130/90. It's 130 by 90 millimeters of mercury. Units are equally important. That shows that you are well prepared for your exams, right? This is particularly there. So, Megha, your patient's blood pressure is controlled. Say the patient is coming to you in a PSA clinic with a blood pressure of 120 by 74 millimeters of mercury on these particular drugs, which you have already mentioned. So what will be your pre-anesthetic advice?
So my pre-anesthetic advice will be fasting for 6 hours for light meal, 2 hours for clear liquid, written informed consent from the patient. I'll give tablet alprazolam 0.25 mg night before surgery and on the morning of surgery. I'll ask the patient to continue tablet amlodipine and omit tablet telmisartan. I'll give anti-aspiration prophylaxis with tablet ranitidine 50 mg night before surgery and on the morning of surgery, along with tablet metoclopramide 10 mg night before surgery and on the morning of surgery.
Okay, so you have specifically mentioned that you really want to continue with the amlodipine and you want to switch off, you don't want to give telmisartan on the morning of surgery. Any specific reason why are you omitting telmisartan?
Sir, with the drugs like telmisartans, which are angiotensin receptor blockers, there are chances of increased refractory hypotension in the intraoperative period. So I have asked the patient to omit telmisartan on the morning of surgery.
So mainly the crucial time is the induction of anesthesia, because most of your anesthetic agents also causes a decrease in your blood pressures, right? This is there. So at the time of induction of anesthesia, it has been seen if you give it in the morning of surgery, there'll be precipitous fall on the blood pressure, refractory hypotension. So your patient is on amlodipine as well as telmisartan. Say if your patient is only on the monotherapy of telmisartan for the control of blood pressure, still you would like to omit it on the morning of surgery?
No, sir. Then I would like to continue tablet telmisartan on the morning of surgery, provided that I'll adequately preload my patient before the induction of anesthesia to avoid any hypotension.
Okay, good. So the thing is, if it's a ARB monotherapy, yes, you can be giving it in the morning of surgery, provided your volume status of the patient is good. But if it's a part of polypharmacy, yes, you would like to avoid ARBs in the morning, and rest of the drugs you can be giving it on the morning of surgery, right? This is there. And Megha, do you routinely give this acid prophylaxis, which you have mentioned, ranitidine and metoclopramide, both the drugs in all your patients subjected to surgery, elective surgeries?
No, sir, we do not give anti-aspiration prophylaxis with ranitidine and metoclopramide in all the surgeries.
So why have you specifically said both the drugs in this particular case?
Sir, because laparoscopic surgeries there are increased chances of regurgitation, and plus laparoscopic surgeries have been associated with increased chances of post-op nausea and vomiting. So giving metoclopramide also helps to counter the effects of nausea and vomiting. That's why I have prescribed this anti-aspiration prophylaxis in my patient.
As per the recent recommendations and all, acid prophylaxis contains those PPIs. PPIs are mostly because there is little good talk in last few years about your H2 blockers also. Right? There is good literature on H2 blockers. These are controversial drugs, but still at some centers it's being still used. Mainly because PPI is a little expensive, right? This is there. And regarding your metoclopramide, right, it is not routinely being practiced. None of the recommendations says, but yes, those patients who are, are more prone to have a post-operative nausea and vomiting, you have to give metoclopramide. Okay.
Okay, now thus we have written the preoperative advice. The patient follows all your pre-op orders, reaches the OR next day. So what is your plan of anesthesia for this particular patient?
Ma'am, my plan of anesthesia would be general anesthesia with controlled mechanical ventilation using a laryngeal supraglottic airway device of the second generation. That will be my plan of anesthesia.
Okay. So I hope we all know how to prepare our theater, machine check, etc. We are not going into the details. We are running a bit late. So any specific, preparation with reference to the surgery you require? Any specific preparation you require?
Ma'am, since this is a patient of
Not
hypertension.
really. Okay, yeah.
Ma'am, since this is a patient of hypertension, I would make sure that I have drugs necessary with me to blunt the intubation response, ma'am. So I will make sure that I have those drugs that are available with me.
All right. Okay. So what is the monitoring that you will institute in your patient?
Ma'am, I would ask for I would ensure that there is ECG monitor and non-invasive blood pressure monitoring, pulse oximetry, capnometry, temperature monitoring, the airway pressure monitoring. And if there is a patient of compromised cardiovascular status, cardiopulmonary status, then I would go for an invasive blood pressure monitoring and a continuous ST segment analysis.
Okay. So, right.
Yeah. So thus you have mentioned in your plan of anesthesia that you will be going for a supraglottic airway device, that to a second generation supraglottic airway device,
Yes,
right? So mostly in surgeries, I've seen people being putting endotracheal tube. So why have you selected supraglottic? Is there any advantage over endotracheal tube?
Yes, sir. We can avoid the intubation response that is we can avoid the laryngoscopy and intubation response that is associated with securing a endotracheal tube, because laryngeal mask airway will not cause that much. response. Also, sir, in the post-op period, the incidence of post-op stridor as well as sore throat will be lesser with a laryngeal mask airway, sir.
So certainly second generation supraglottic devices has a lot of advantages over your this thing, because it has a drain channel, so aspiration is not a concern.
Yes.
Right, that is particularly there because you can insert a nasogastric tube through a second generation supraglottic airway device, right? And the stress response of laryngoscopy and intubation, as you've already mentioned, is certainly lesser with the superior, because don't forget your patient is a hypertensive patient. So you would like to, reduce the kind of hemodynamic stressor response while you're inducing and, securing the patient's airway. So it's much better than endotracheal tube with regards to your hypertensive patient also. Right, so that's why your because stress response is much lesser with supraglottic, second generation supraglottic airway device.
So, Megha, now tell us, everything is prepared. How will you induce anesthesia for this patient?
Yes, ma'am. I will secure a 20 gauge IV intravenous line in non-dominant hand of the patient, and I'll start fluid through that cannula. Then
Speak a bit louder, please.
I will secure 20 gauge IV cannula in the non-dominant hand of my patient, and I'll start intravenous fluid through the other cannula. I will adequately pre-oxygenate my patient, and I'll start with my induction agent, which will be injection fentanyl, which will be given with a dose of 2 mics per kg. And after that, I'll be using induction agent, I'll be using injection propofol. I'll be giving in the titrated doses till there is a loss of verbal response. After the loss of verbal response, I'll check the adequacy of ventilation. And after checking the adequacy of ventilation, I'll give injection, I'll give non-depolarizing muscle relaxant, which will be injection vecuronium in the dose of 0.1 mg per kg. And I'll ventilate my patient for 3 minutes with a mixture of oxygen and nitrous in 50-50% and using isoinhalational agent isoflurane in 1 volume%. After 3 minutes, I'll secure my airway with Procel of size 3. And after securing airway, I'll check the placement of my device. I'll aspirate through the RT and empty my stomach. And then I'll see for the bilateral chest rise. And then I'll put my patient on ventilator. And I'll choose a pressure control ventilation for my patient.
Okay, any particular reason that you have used propofol as your induction agent?
Yes, ma'am. Propofol, since this is a hypertensive patient, propofol can also decrease, propofol will attenuate any response which will be coming at the time of securing airway. So I have used propofol for my patient.
Any other advantage? Thus, any other advantage?
Ma'am, the propofol is associated with the intravenous propofol is associated with a decreased hemodynamic disturbances. Also, the time that is required for the induction of the securing the airway is decreased with a
Any
propofol.
other? We mentioned that this can be done as a daycare surgery. So
Yes,
what?
ma'am.
Yes, ma'am. Yes, ma'am. The
Decrease-
recovery,
Decreased risk of PONV will be there
yes,
with propofol.
Ma'am, the chances of post-operative nausea vomiting is lesser when we are using propofol. Also, ma'am, the
Yes.
recovery is very clear-headed. The post-operative
Yes.
cognitive and dysfunction is very less.
So those are the requirements of daycare surgery.
Yes, ma'am.
Okay, so you said that you will put the patient on ventilator. Okay.
So, Megha, can you tell me what are the ventilatory settings would you like to keep?
Sir, I'll keep pressure controlled ventilation for my patient. I'll check after device placement. I'll check the cuff pressure and I'll check for the oropharyngeal leak pressure for the device. And I'll put my patient on pressure controlled ventilation. Pressure controlled ventilation will help me in better oxygenation and better control of airway pressures throughout the surgery.
Okay, so any other ventilatory, strategy you would, in addition to the mode of ventilation, any other ventilatory strategy you would like to, mention?
I would like to go with lung protective ventilation strategy. I'll target my tidal volume in the range of 6 to 8 ml per kg, and I'll apply PEEP to the and use PEEP in my ventilatory strategy.
Okay. So all the postgraduates who are listening us today, we have selected to use a supraglottic airway device. It's always better to go for a pressure controlled ventilation over the volume controlled ventilation. right? That is the thing. And if you're using supraglottic, regular checking of the cuff pressures and the beginning oropharyngeal leak pressures, they're very, very important. You always speak up when you're giving, using supraglottic and telling us about it. And adding PEEP is again very important something in such cases.
Okay, how will you maintain anesthesia, Megha, for this patient?
Ma'am, I'll maintain anesthesia with a 50:50 mixture of oxygen and nitrous oxide and isoflurane, and injections of vecuronium and injection fentanyl as and when required.
There are concern about using nitrous oxide in lap surgeries, especially the surgeons, some surgeons don't like. So why is nitrous? Would you be using nitrous? You said you will.
Yes.
Why would you like to use nitrous?
Ma'am, nitrous oxide will decrease the risk of intraoperative awareness, and plus there are a number of studies which have shown that there is no correlation between the use of nitrous oxide and post-op nausea and vomiting and intra-op bowel distension. So I would like to go ahead with the use of nitrous oxide for in my ventilation.
So regarding DAS, any other ideas about the concern for bowel distension, which the surgeons, as soon as they see that we are using nitrous, they always ask, shut it down, shut it down.
Ma'am, as Megha mentioned, ma'am, there is all the studies that have been conducted have not proven, have not shown that nitrous actually causes bowel distension. In fact, the studies, when the surgeons were asked in the post-op period as to during the intra period, when they observed bowel distension, they could not identify whether it was due to CO2 or due to nitrous. So, ma'am, I would like to go with nitrous. Also, as she mentioned, nitrous, there's been all the studies that have been conducted have shown that there is no associative factor, that nitrous is not a causative factor for postoperative nausea vomiting.
So, is there any other anesthetic technique by which we can not use nitrous and still do our case
yes,
very nicely?
Yes, ma'am. Ma'am, we can go for a total intravenous anesthesia. A total and moreover, ma'am, because this is a daycare surgery which is lasting a very short duration, a total intravenous anesthesia with propofol would be a great alternative to this technique. Ma'am, in total intravenous anesthesia, we could use a TCI or a manual controlled infusion anesthesia.
I think TCI is always better.
Yes, ma'am. TCI is better as compared to a manual controlled infusion device. So, ma'am, TCI propofol, we can use, ma'am, various models.
Right. Okay.
One thing to all postgraduates who are listening to us today, don't use your familiar words which you're using in theaters. Nitrous. It's nitrous oxide. In an exam, always be in a habit of speaking complete things. Not nitrous, it's nitrous oxide, right? Don't use short forms in your exams.
So, Dr. Amit, yeah.
Yeah, Dr. Das, in what position, the pneumoperitoneum is generally created, right? Can you please tell me that?
Sir, the pneumoperitoneum is created with the patient in the supine position, sir.
In supine position, and thereafter you will be making the surgical position?
Reverse Sandling book, sir, with head up and right ups.
Okay, perfect. So your surgery has started thus, and pneumoperitoneum has already been created. Surgeon is dissecting, that is particularly there, and certainly you noticed that there is a drop in the oxygen saturation. Your saturation was around 98, 99%, and suddenly it's keep on falling, becomes 88, percent, and your EtCO2 values, which are coming on monitor, rises up, and in the range of now 51, 52 millimeters of mercury. So if these two things are happening, what comes to your mind and how will you proceed?
Sir, could you repeat the EtCO2 findings, sir?
Yeah, the thing is like the oxygen saturation is falling, right? It's from 98, 99, it's falling. It's 88 now, and your EtCO2, which was normal earlier, and after 15 minutes, it starts rising, and it is in the range of 51, 52 or something like that.
Sir, first I would like to... Yes, sir. Sir, first I would like to auscultate the chest, sir, of the patient.
Okay.
If I find that there is a decreased air entry, hyperresonance that is observed, so that could be most likely due to a capnothorax that has occurred, sir. Sir, also I look at the
EtCO2 is rising.
Sir,
Yeah.
ETCO2. Okay. Sir, then the likely cause would be endobronchial intubation, sir.
Okay. So would you like to check something? Would you like to, how will you proceed in this particular thing?
Sir, firstly, I would ask the surgeons to stop the surgery there. Stopped. Then I would change the position from the reverse trendline bulk to the supine position, sir. I would deepen the plane of anesthesia, switch to 100% oxygen, then take on the manual circuit, and then, sir, do a gentle laryngoscopy and see and try to withdraw the tube, sir, to the right position.
Okay. So what you were expecting?
Sir, it's possibly it's because of a endobronchial intubation that has occurred that the
So your endotracheal
so
tube might have gone endobronchial, right?
endobronchial. Sir.
Why in this particular surgery there is a chances that the tube has gone endobronchial?
Sir, because of increased during the creation of pneumoperitoneum and the increased intra-abdominal pressures that are observed, that could have caused the cephalid displacement of the diaphragm as well as the carina. And because of that, the tube may have gone from the carina into the one of the bronchus.
And you may see there are certain hemodynamic changes along with that, whenever your
Yes,
tube goes into the one side. So you should treat the patient in toto, right? Always you should confirm whatever you are thinking, right? By the examination, the auscultation he has done. You can check the pressures also on the monitor, right? Airway pressures as well, right? This is there. And then under vision only, you should be pulling out the tube under laryngoscopic vision, right?
Amit, I think we'll just be brief so that we can cover more questions. Okay, Megha. So after 15-20 minutes of creation of pneumoperitoneum, suddenly you notice that your oxygen saturation has gone down. Even the ETCO2 has gone down, and there is rise in the airway pressure. And when you auscultated that made you auscultate the chest of the patient, and the air entry was decreased on one side. And there was on percussion, there was a hyper resonant note. So what has happened to your patient?
Capnothorax
What could be
might
the
have
usual reason?
capnothorax might
Pardon?
have happened to my patient. The
Capnothorax. What
Yes.
is capnothorax?
Capnothorax is the presence of carbon dioxide in the pleural cavity. Due to the creation of pneumoperitoneum, there is increased intra-abdominal pressure. So there might be any embryonic connections between the pleural cavity and the peritoneal cavity, which might get opened up. So capnothorax can happen during these surgeries.
So how will you manage such a situation? What will you do? Just tell me, scene is in front of you, stepwise, what will you do?
Ma'am, I'll switch to 100% of oxygen and I'll apply a PEEP to the patient and I'll wait for the spontaneous resolution of capnothorax. But if the capnothorax is not getting resolved even after applying PEEP, and then I might have to go ahead with the thoracocentesis.
Is there any situation where you do not use PEEP and mandatorily you do a thoracocentesis?
Yes, ma'am. If it has happened due to any rupture of bullet, then we do not give PEEP. The patient will directly.
So if your patient has a pre-existing emphysematous bulle, so the treatment will not be giving PEEP. You will straight away mandatorily go in for ICT insertion.
Yes.
Okay.
So certainly, that's which you mentioned in the last question, right? That you can only go endobronchial once you have intubated your patient. Your patient, you have put a supraglottic airway device, right? So that was not the question which has been asked is in those centers where endotracheal tube has been put for laparoscopic cholecystectomy. That if such scenario happen, there are chances that the tube can go endobronchial. But certainly, if you're using supraglottic airway device, that is one of the advantage of supraglottic airway device, that there is no endotracheal tube, so it can't go into one of the bronchuses. So, question to you, Das, that in between the surgery, say 15 to 20 minutes of the start of the surgery, you suddenly noticed that the patient's blood pressure shoot up to say somewhere in a tune of 180 by 108 millimeters of mercury. How will you proceed? What comes to your mind and how will you manage?
Sir, I would want to rule out a few things before I can diagnose what has actually happened. What is the reason for the increased arterial pressures? I would ensure that the depth of anesthesia is adequate. If it isn't, then I would increase the MAC by increasing the inhalational agent. I would ensure that the analgesia that has been provided is adequate. If there has been a deficient in the analgesia, I would top up with injection fentanyl top bolus. And sir, if all this has been ruled out, then, sir, the possible cause that has possible reason because of which the arterial pressures have increased is probably because of the pneumoperitoneum and the increased intra-abdominal pressure that have resulted in a increased total peripheral resistance, which has resulted in an increased afterload. So, sir, then I would I would try to start an infusion of injection nitroglycerin at 0.3 to 0.5 mics per kg per minute, sir. And also, sir, I can use injection labetalol, injection metoprolol can be used. These are the various agents that can be used.
So, firstly, you have to make why the things are happening, and then only you'll be treating. To all the postgraduates who are listening us, please don't say, okay, we can, I can, right? What will you do? How will you manage, right? So, first drug, if it's not getting controlled with this, my second choice will be that. If it's not getting controlled, my third choice will be that, right? This is particularly to decrease this hypertensive response or something. Any new agents should be knowing of, any new agents to decrease this hypertensive response, because your patient is a known case of hypertension. They may there may be surges of BP during the surgery, right? Other than nitroglycerin and beta blockers.
Sir, we can use injection lignocaine also, sir, to blunt the intubation
Lignocaine can be
response.
used. These days, dexmedetomidine can also be used. The infusions of dexmedetomidine also. That
Dexmedetomidine also can be used, sir. Yes, sir.
Yeah. So to suppress these responses. So it should be known.
Esmolol also can be.
Esmolol is a very short-acting agent, right? Particularly, you can give a bolus, you can see the effect, but if you know that you have to give beta blockers, metoprolol is better.
Okay. Megha, now the surgery has been going on. It's more than 30 minutes. And again, you were a very vigilant anesthetist and you suddenly notice that your EtCO2 has gone up, abnormally high. Though your SpO2 is normal, your airway pressures are normal. Again, you auscultated the chest of the patient. It was normal, though the breath sounds were, they were quite distant on auscultation. But when you had pressed your stethoscope onto the chest of the patient, you felt a bit of crepitus and swelling there. So what can you think, what all can happen with these parameters to your patient?
Carbon dioxide subcutaneous emphysema would have happened to my patient.
So what is the usual cause of this entity?
The insufflation of carbon dioxide in the subcutaneous plane would have.
So it is accidental extraperitoneal insufflation. But it is intentionally also done. Extraperitoneal insufflation is also done in certain laparoscopic procedures. Yes. Can you give me some examples?
In some hernia procedures, external, and some renal surgeries,
and pelvic lymph node dissection, etc. Yes. They can be done. So if you have diagnosed your patient with carbon dioxide subcutaneous emphysema, how will you manage the situation? What will you do?
Ma'am, I'll inform my surgeon that a subcutaneous emphysema has happened and ask him to slow down the rate of insufflation and maintenance. And I'll increase the minute ventilation of my patient. My main concern will be the increasing of end-tidal carbon dioxide. I'll increase my minute ventilation by approx 15 to 20%, and I'll continue monitoring my patient.
So you see, something very important, any rise in EtCO2, which occurs when your EtCO2 has plateaued approximately 30 minutes. If it occurs, then this is a big hint towards this clinical entities, carbon dioxide subcutaneous emphysema. And moreover, just by increasing your minute ventilation does not, rapidly restores normocarbia in this patient. You must remember. So you must keep on mechanically ventilating the patient till you are able to restore normocarbia, and the surgeon can resume surgery with low intra-abdominal pressures. He can resume the surgery. However, if this has happened, it will eventually resolve. But you need not extubate your patient because of this. Okay, you can carry on along with the monitoring. Okay.
So, Megha, you told that you have to increase the minute ventilation. How will you do so? What parameter would you like to, increase?
Sir,
during your ventilation of such cases?
Sir, I would like to increase respiratory rate to increase my minute ventilation.
Okay. So respiratory rate over the tidal volume, right? Respiratory rate needs to be increased. So thus, any other intraoperative complication of laparoscopic cholecystectomy?
Sir, there is a chance of carbon dioxide embolism also that can occur during insufflation and creation of pneumoperitoneum that is occurring.
Okay, so what are the risk factors of CO2 embolism, gas embolism?
Sir, the risk factors would include the size of the molecules, the weight of the molecules, the diffusibility of the gas, its solubility in blood, the size, the cavity in which it is getting insufflated into, and the blood flow of that area. All these would be the various factors that also the the region where it is getting so if the carbon dioxide is directly insufflated into a vein or artery, then that would obviously
Directly into
immediately
any
cause an
vessel,
embolism.
it is catastrophe, right?
Yes.
So that is there. So always remember that prevention is better than cure. So how will you like to prevent CO2 embolism from happening?
Sir, firstly, I would preload the patient with adequate I would maintain a hydration and preload the patient properly before starting my surgery, and that is one of the biggest ways we can prevent CO2 embolism.
Yes, and anything to do with the rate of insufflation or something
yes,
like that?
Rate of the intra-abdominal pressure, the pressure at which we are creating the pneumoperitoneum can be decreased to around 10 to 12 mmHg. At the same time, the rate of insufflation can be decreased to less than 1 liter per minute. That would also help, sir, in preventing carbon dioxide embolism.
Okay, so intraoperatively, what clinches you that the patient has CO2 embolism, and how will you manage it?
Sir, if carbon dioxide embolism has occurred, there would be a sudden fall in the arterial oxygen saturation. There would be a sudden fall in the EtCO2.
Arterial oxygen saturation you are monitoring?
Sir, the SpO2, sir, the
SpO2, this is the capillary oxygenation.
capillary oxygen. Yes. There would be there would be desaturation. There would be decrease in the sudden fall in the EtCO2. And sir, also on the monitor we can see ECG changes that can occur. There may be bradycardia or arrhythmias that may suddenly show up. And there can be sudden hypotension can occur. So all these can be the different clinical findings that we'll see in.
How will you manage your patient?
Ma'am, I will firstly inform the surgeon that CO2 embolism has occurred and ask them to stop the surgery. Then turn the patient, get the patient back to supine position, stop nitrous oxide and take them on 100% oxygen.
They should deflate the cavity
Yes,
also.
ma'am. Deflate the abdominal cavity. Then rapidly rush fluids in order to correct the hypotension. And if the fluids are not enough, then we have to start vasopressors also. Ma'am, then we can, before that, we can also go for Durant's position, ma'am. Durant's position was basically head down and right up position, which helps in removing the gas embolus away from the heart, away from the right ventricular outflow tract. Also, we can go for external cardiac massage, ma'am. External cardiac massage has been shown to decrease the size of the emboli and move them further away from the heart. These are various things that we can.
It breaks the embolus into
Yes,
small micro bubbles.
Yes, ma'am.
So in the hope that they get away from the outflow tract and remove the obstruction. Okay. So let's now the surgery is complete. Time to extubate the airway of the patient. So yes, Megha, any specific things you would like to take care during extubation?
Yes, ma'am.
You had used ProSeal LMA for this patient.
Yes, ma'am. I'll make sure that my surgeon has inserted local at the port site and on the liver bed to decrease the chance of to decrease post-op pain. After that, I'll ensure a proper full recovery from the effect of my muscular relaxing agents. And after ensuring a full recovery, when the patient is awake and following commands, then I'll remove my LMA proceed, and I can also use lignocaine to decrease the response of extubation in my patient. And
so all the precautions that you had done to inhibit the pressor response during intubation should be taken care of during extubation also, besides taking care for this post-op analgesia. So we have successfully extubated the airway of the patient. All is well. We have shifted the patient to post-op recovery area. Right?
Yes.
Before that, if at all thus, you will be able to tell me that yes, you have taken out the endotracheal tube or a supraglottic device, whatever you have put. Right. Before that, one thing has to be cautiously done, that the desufflation should also be slow, right? Particularly there, and ensure the complete desufflation, right? Surgeon should ensure the complete desufflation. So your case is done as your patient, you've extubated and you've got to shift the patient. So what are the post-operative orders would you like to give? You jot down in your case sheet.
Ma'am, sir, I would ask the I would advise to keep the patient NPO until 4 to 6 hours after the surgery. I would
Again, it's
advise
nil per oral.
nil per oral.
Nil per oral, not NPO.
Yes, sir. Nil per oral, 4 to 6 hours after the surgery. I would ask them to keep the patient in the propped up position. I would ensure providing supplemental oxygen in the post-op period for around 4 hours. Then I would advise injection paracetamol 1 gram IV thrice daily, and I would ensure that the fluids are maintenance fluids, that is ringer lactate, is also provided at the maintenance dose.
So whenever any postgraduate is writing the post-operative orders, it has to be very complete. If you're saying IV fluid, it doesn't make any sense. You have to mention which IV fluid, what is the rate of the IV fluid would you like to give, right? This is their oxygen, by which device, at what time, what flow rate. So your post-operative orders should be very complete orders. So you mentioned about oxygen thus, right?
Yes,
so routinely in all the surgeries, because this is a daycare procedure, minimally invasive procedure, right? You give oxygen to all your patients?
Sir,
In
yes, sir.
post-op?
In this patient, I would give, sir. Sir, in laparoscopic cholecystectomy, it has been observed that the PaO2 in the post-op period is low. So, sir, I would advise for post-op oxygen therapy, sir.
So basically, due to the creation of pneumoperitoneum, you feel like that
yes,
there's
sir.
some time in the post-operative period,
Yes, sir.
maybe your
The
arterial
post-op
oxygenation is hampered.
ventilatory parameters
You need
should
to
be.
supplement for say almost 2 to 3 hours post-operatively,
Yes,
and
sir.
thereafter, if everything goes okay, you can off the oxygen, because again, oxygen is a drug. But in this particular case, you would like to give, but not all the cases,
Yes,
right? Warrants oxygen, right? This is there. So if you can quickly thus enumerate the complications which you can anticipate in the post-operative period.
Sir, because of the carbon dioxide insufflation, there can be right tip shoulder pain that can occur in the post-operative period. There can be post-operative pain due to the surgery itself, that is a visceral pain that can be felt by the patient. Then there can be post-operative nausea, vomiting that can occur, sir. Then there is post-operative, there is a post-operative ventilatory, because of the VQ mismatch that has occurred pre-op, there may be episodes of desaturation also, and post-op ventilation to come back to normal.
Basically, keep on speaking the normal things. You don't have to enumerate 10 things in all the questions, right? On all the answers, right? This is there. So laparoscopic is these days a daycare procedure, right? Minimally invasive procedure or something like that. So oxygenation, ventilation, wale jo complications hai na, that should be just to complete the list. And if you don't mention it also, it's okay, right? That is particularly there, right?
Okay, we have not elaborated on the post-op analgesia. Megha, can you just quickly tell us how will you maintain analgesia in this patient?
Yes, ma'am. My best approach will be multimodal analgesia. I'll start with the preemptive analgesia in the operating theater itself. I'll give injection dexamethasone and injection diclofenac to the patient, along with injection paracetamol. Towards the end of the surgery, I'll ensure that the local has been infiltrated at the port site and the liver bed. And apart from multimodal analgesia, there are other blocks which have been being used, like
Can you just mention those blocks which can be used?
yes, ma'am. Bilateral subcostal transversus abdominis plane block, erector spinae plane block, and quadratus lumborum block can be used for the analgesia in for a laparoscopic cholecystectomy.
So ultrasound guided use of these blocks is very effective and safe method of providing analgesia to these patients. So we are talking about doing this surgery on daycare basis. So can you bring in ERAS components into this surgical procedure? What is ERAS?
Yes, ma'am. ERAS is enhanced recovery after surgery.
So what components can be, brought in for this laparoscopic surgery?
Starting from the preoperative period, ma'am, I'll educate my patient and I'll counsel my patient about what is the surgery is, what he will be or she will be going in the operating theaters, what all things will be done to him, and I'll make sure that my patient is fully optimized for her blood pressures, and I'll limit the fasting hours for my patient, and I can also go ahead with carbohydrate loading for my patient prior to the
What's
surgery.
that? Carbohydrate loading?
In carbohydrate loading, we'll give a carbohydrate-rich fluid to the patient 2 hours prior to the surgery to decrease the stress response.
Okay. The intraoperative steps?
Intraoperative steps will be, I'll avoid the use of long-acting opioids. I'll use short-acting opioids. I'll limit the use of benzodiazepines like midazolam. I'll maintain a normothermia, normovolemia for my patient, and analgesia analgesia will be well covered, and I'll give prophylaxis for post-operative nausea and vomiting in the intraop period.
So post-op components?
In post-op components, I'll ensure early ambulation, early nutrition to the patient. Any post-op nausea, vomiting which is happening should be aggressively treated, and we will ensure early feeding.
Which will ensure?
Early feeding.
Early feeding, early ambulations. Okay, and you will take care of all the problems which Das has just enumerated. Okay, I think that's it, Amit. Very well done.
One thing I would like to ask Das. Das was mentioning about post-operative orders. Do you think, Das, whatever has been discussed and whatever you're told is complete? Or anything which you're missing in your post-operative orders?
When the examiner asks you such question, that is a clear hint that you have missed something.
What was your patient?
Sir, yes, sir. The patient was a hypertensive patient. So we'll ask
your
them
patient was on antihypertensive agents?
Antihypertensive medication. So the antihypertensive medication will be continued, sir. As and when
You have to tell the
Yes, sir.
surgeon when the medication to be restarted.
Restarted, yes, sir.
Rather, it should be a part of your post-op orders which you have written.
Yes, sir. Yes,
clearly.
It should be clearly written, right? Post-op orders should be very clearly written, right? That is something very, very important.
So, and in the post-op period, besides monitoring other things, you will monitor the patient's blood pressure or any, cardiac problem. Okay. Patients with the more serious cardiac ailments can go into congestive cardiac failure post-operatively also. So don't forget the comorbidities of the patient. I mean, you are not supposed to just concentrate on the laparoscopic procedure per se. Okay. Anything else, Amit?
I think, ma'am, we are done. Most of the things have been discussed.
We can see the questions in the chat box.
Anybody can read it for us?
Yeah, Shrutika
yes,
and Riya are there. Shrutika, Riya, take over.
Yes, sir. A very wholesome discussion for the topic today and very apt explanation given by our PGs. Let us start with the first question. Dr. Mohan has asked if how to check leak pressures.
We would prefer our postgraduates to reply.
Yes, sir. After checking the cuff pressure, which will be around 60 centimeters of water, I'll check for the oropharyngeal leak pressure. For that, I'll give 100% oxygen and I'll keep my flow rate till 3 liters of per minute. And I'll close my APL valve and I'll took my patient on a manual mode. And then I'll see for the rise of pressure. And meanwhile, I'll look for any sounds or look for sounds, and I'll place my hand on the suprasternal notch to appreciate any leak, and I'll see the rise of the pressure. Till my pressure has maximum rise, I'll take that point as my leak pressure until the sounds has come.
Whenever they have been plateaued, right?
There has been plateau.
Oh. I see a question just flashing. I think, Megha, what is the role of regional anesthesia? Somebody asked, no?
Yes.
So what are your views? Yeah.
Regional anesthesia has also been used in laparoscopic surgeries. It has both its advantages and disadvantages. Regional anesthesia, being the advantage of regional anesthesia is that there are less chances
By
of
regional, you are talking about
I'm
specifically
ma'am, both
spinal?
central neuroaxial blockade, spinal,
Spinal anesthesia.
and
Okay, all
thoracic
right.
segmental
Because
spinal.
I think at certain places, spinal anesthesia is being used, isn't
Yes,
it?
ma'am.
So tell us, what are your views about spinal? Yeah.
Some of the advantages are there can be early diagnosis of complication. There are decreased chances of PONV with the post-operative nausea, vomiting with regional, and decreased risk of analgesia, decreased post-op pain in the patient. But there it has been in its own disadvantages. Like the patient discomfort has been more in regional anesthesia, and plus there is a right shoulder tip pain, which is more in a regional anesthesia, and more so in regional anesthesia, a higher level of block is required till T4. That can exaggerate the hemodynamic responses which is being observed with a laparoscopic cholecystectomy. Because of the pain and anxiety, we usually start sedation for that patient. So starting sedation will also decrease the it will lead to hypoventilation, which will further compromise our excretion of carbon dioxide. So it has its both pros and cons, although it has been used in laparoscopic cholecystectomy.
Okay. So I think people who are using one thing very important is you, besides all these problems, your surgeon needs to be very good at his surgical procedure, because it entails a lot of problems. Okay? Patient can complain of pain intermittently when he's insufflating, shoulder tip pain, etc. So
as a postgraduate, I suggest that you should always be telling that general anesthesia with controlled mechanical ventilation is the safest and the gold standard option to get the laparoscopic cholecystectomy done. However, it can be done in spinal anesthesia or the regional anesthesia in the resource limited settings.
the next question, Dr. Ria.
Amit, don't in the postgraduate class, that is not to be answered in the resource limited setting. These are the post-graduation classes. Any examiner coming will not be able to hear the spinal anesthesia. That is for the practice is a different thing.
That's why we haven't touched that. That's why we have said that the
I think better
the safest option is
we stick to only to the postgraduate class
because
here.
there was a question in the chat box. That's why we discussed.
Ma'am, because the practitioners are also listening to this class and they will like to get their answers verified by us.
That's why I summed up like that. The general anesthesia with controlled mechanical ventilation is the safest and the gold standard option to get the laparoscopic cholecystectomy done. That's it.
Any other question?
The postgraduate should put a full stop over there.
But that's fine.
Yeah, it's the name is not mentioned, but they're asking if there is if any caution to be exercised while extubating the patient.
I think this person who is asking must have joined late. We have elaborated enough during extubation. I think we can take the next question.
Everything was conveyed by the PG students. Everything was.
And Muthukumar Rajgopalan has been asking that how to fix the tube exactly in mid-tracheal position so that accidental endobronchial intubation can be avoided.
I think he needs to read his basics. That is my answer is. Okay.
Okay. It's a very fine answer also by madam. But the best part, if you ask anybody, if you go to the first year teaching of the PG students, the teacher can tell you if you don't have any other, the ultrasound to assess the whatever the things, you just push the tube to the carina, just pushing your tube to the carina, then see where the entry is going to be on one-sided. Then you start withdrawing it at least 3 centimeter or 4 centimeter. That's an ideal space. And till if for a female patient, it is around 20 centimeter, over the male patient 21 centimeter, depending on the average length of the neck also. I think all these things will come into play when the airway assessment is done. So every neck is not the same. The longer neck, you have to fix the tube at 22 also. So
and there are certain formulas also. If you're doing for a orotracheal intubation, there are certain formulas that how much the depth of the tube should be there. You should read those formulas also.
Yeah, everything is given in the airway assessment and where the tube can be fixed. And these are very basic questions.
And ultimately, it's the auscultation. Auscultation is the key.
And visual monitoring, during visual monitoring, if the endobronchial intubation has occurred, definitely there's a drop in the SpO2 also.
And another question which is popping up repeatedly is propofol is not a replacement of nitrous. Sorry, you have gathered us wrong. We never said that propofol is a replacement of nitrous. My question was any other anesthetic technique by which this laparoscopic cholecystectomy can be done. So the answer which was given by Das was total intravenous anesthesia. In that, ideally, nitrous oxide is not used.
Yeah,
So
only oxygen is used. In TIVA, only oxygen is used.
Air is the best thing. If you have air in your centers, air is the best thing for total intravenous. If you don't have air, yes, you can use oxygen.
Any other question, Dr. Shrutika?
No, ma'am, I don't think I can.
Somebody has asked the use of abdominal wall lift system in laparoscopic surgeries.
I think that also Das explained very nicely. The gasless laparoscopy we said.
I think in the modern era where you have got all the facilities available with you, you are going for the minimal invasive thing. Why you want to go to the rudimentary things of uplifting like an animal, from putting all the retractors, giving injuries to the soft tissues, then causing post-operative morbidity, rather than adhering to those where it is required. I don't think so that is required nowadays. You have got so many good monitoring gadgets. You have got so much good anesthetic techniques. You have got the knowledge of medicine and everything. Those things are totally obsolete nowadays.
So one thing from my side, which is there to all the postgraduates who are listening, that you are preparing for your exam, you are reading standard textbooks and all, right? But don't forget the things which you have been doing in last years. This is such a simple case. You might have done nth number of laparoscopic cholecystectomies. Whenever you are answering in your Viva VOC, you just remember one case which you were getting it done and speak up in your Viva VOC according to your practice, right? The theory part will be supporting to that. But while reading the theory, you don't forget your things which you do in your theaters.
Yeah, that is true. Absolutely true. For these classes, these are supplementary classes for the postgraduates. The main things are the books. Main thing are the books. You have to read the books only. These are just a supplementary classes to the books. So whatever being taught in the books, you should stick to that. These classes just help to tide over those questions which you may not be able to find in the books.
So suppose just one example, if for the blood pressure control intraoperatively, you may be routinely using nitroglycerin. So in your exam, say nitroglycerin, don't utter that I will be using nifedipine, I will be using nicardipine. If you haven't used anyhow in your clinical practice, you don't know the dose, you don't know anything. So just remember your case and speak up in your exam.
Okay. I guess there are no further questions. So the
I have
PG
questions.
really
Shrutika, I have got
answered
questions.
everything very well.
Shrutika, I have a question
Yes,
for the
sir, you
postgraduate
can.
now. I'm another external examiner, so I will be asking one question to them. Now, there was a discussion about the use of the supraglottic airway devices for the laparoscopic cholecystectomy. Now, you are using a supraglottic airway devices. Now, your stomach is full of gases, maybe some remnants are gastric remnants are there, residuals are there. How you will go insert your this or Riles tube, and how you are going to maintain the patency of the supraglottic airway devices when the Riles tube already inserted before insertion of the supraglottic airway devices, or after the establishment of the supraglottic airway devices connection, you are going to insert the Riles tube. So tell me that how you are going to manage.
So with the insertion supraglottic airway device, I'll insert my Riles tube, and through the Riles tube, I'll suction the contents out, and
No, how are you going to insert? I'm telling you, it is a difficulty. While you are inserting a Riles tube, when you are already secured the airway with a supraglottic, whether it's a ProSeal or it's a first generation, second generation, third generation, you have already secured the airway. Now, how are you going to put the Riles tube when you are facing a difficulty? What is the next step?
So I'll
A surgeon is asking, I want a deflation of the stomach. You have filled the stomach with the gas and you have put up a, maybe a slight difficult airway. Then rather than you may have planned for the supraglottic airway device. Now you have put it, the stomach has to be deflated. Now you want to put a Riles tube. You are getting a difficulty in a negotiation of the curves or whatever it is. So what is the next step?
Sir, if my Riles tube is not negotiating through my device, then the placement of device might not be correct. Then I'll remove my device and I'll insert the proceed with a finger technique with the already RT
That
insert.
means
Yeah.
when you take out your patient is paralyzed. Because many times I don't think so that everybody inserts the Riles tube in 100% of cases. Many times it's not required also. Unnecessary putting going for the patency of the esophageal sphincter. You make it open during these laparoscopic surgeries. With the rise of intra-abdominal pressure, there are always chances of higher regurgitation in these cases. That's why when you have put up a already secured airway, you are having a difficulty in Riles tube insertion. Now it's a very difficult to do laryngoscopy in that thing. It's very difficult to do laryngoscopy. You might displace the airway device. It's always better to take it out, but you will have a very limited time of putting the Riles tube inside it. Again, you have to put the supraglottic airway device back again to that position. But the only disadvantage with supraglottic airway devices is when you have again reinserted the Riles tube, now you're putting the supraglottic airway device, you are at least maintaining a patent connection between the trachea and the esophagus. Riles tube is going to give a patent esophageal sphincter. Any rise in intra-abdominal pressure may put the regurgitant fluid back into this whole of this supraglottic devices, which can again which can again do the channeling into the trachea. So that is one major complication in the supraglottic devices where people are recommending the use of that thing. I think in such cases where the Riles tube insertion is there, it's always better to go for the endotracheal intubation. In your PG answer, that it should be there rather than going with experimentation or some adventures that I will use supraglottic airway devices. Until and unless there is some emergency, there is a life-threatening airway difficulties, you are not able to secure the airway, very difficult to intubate. So many conditions in the airway difficulties are there, where the indication is definitely there for supraglottic airway device. So in PG careers, in the PG final examination, I think when such questions are asked, better to go for endotracheal intubation. You save all the complications associated with these type of procedures. Yeah. Anything
Dr.
else?
Batra, can I just add a comment
Yeah,
on
please,
your
ma'am.
answer? Sorry.
Please, ma'am.
Sorry, I'm very sorry, but I do beg to differ. I mean, world over, supraglottic devices are being used for laparoscopy, but as you very correctly, I mean, the importance you laid upon this problem of, the tract being patent because of insertion of Riles tube. There are certain, whenever you're using supraglottic devices, one, your patient should be for elective surgery. So our surgery was an elective procedure. So we presume that patient is an adequately fasting patient. Okay. In the pre-op orders, Dr. Megha advised full aspiration prophylaxis. And in addition, our patient did not have any other risk factor for aspiration, regurgitation and aspiration. For example, associated GERD, all right, or diabetes mellitus with autonomic neuropathy, where such patients are prone to gastroparesis and aspiration. So I think the insertion of supraglottis device is,
Yeah, I will tell you the reason, ma'am. I will tell you the reason. The country where we are living, majority of the patients coming for the surgery, majority of them, do not obey the pre-operative disorder. The night at the PAC done by a first year PG, conveyed to the consultant on the table, the consultant sees the patient for the first time. And that patient may have taken something of water, like anything, but they will never say that I've taken a water. And that full stomach is almost a full stomach, or may have taken some tea or biscuits also. Many times it happened. You may take history, they will not give the history. So anytime when you take some these patients, I presume, my presumption is that I always see that all my patients are non-fasting, even though they have fasted for more than 6 hours, because in our setups, with the patient, they don't care. They are not aware of these type of things because they interact with anesthesiologists only for a short time, and the majority of time in the institution with the first year or second year PGs who are doing the PSCs. So how would the things we convey to them? We never convey to them that these are the complications of having even a smaller amount of tea, which may contain a milk, which is almost a complete food. And that may not, gastric emptying may be delayed in these cases. When they, I think, taken at a 6 o'clock, you're taking up the case at 8 o'clock. You have a chances of these things. We may presume something, but it turns out to be a nightmare for us.
Right.
I'm talking
that I fully agree with you. The the pre-op orders should be strictly followed, and you should select which patient should you be using a supraglottic device or not using a supraglottic device. So you really have to be very careful where you are using supraglottic. Plus, the person who is using it should have good experience with the use of supraglottic devices in normal surgeries also, besides laparoscopic surgeries, before you use it for as a definitive airway device for lap surgeries. I agree with Dr. Bajwa's point of view in this respect. Yes.
Whatever you are speaking, that this is my technique of choice, so you should be supporting with the justification, that why have you selected it, right? If you have a justification, right, and a clear cut justification, then examiner won't disturb you on that.
I think, Amit, there is another question. Another question is there, that how you manage a laryngospasm or bronchospasm if you are using the LMA. That's another valid question here, I think. I think when you have encountered these complications, definitely you have to secure with a definite airway, and that is endotracheal intubation. If you encounter these things, you remove your supraglottic airway devices. As simple as that.
And
You have to
definitive
intubate.
devices, endotracheal tube. Whenever you're managing this, right, you may use the pharmacological technique, the depth of anesthesia thing. Whenever it's a simple thing in any surgery, laryngospasms and bronchospasm should be knowing how to manage. And certainly, if you're having a supraglottic airway device, it is now the time when you can change over to an endotracheal tube, right? That is my take on that.
To further add to that, if we go very practically, even if you are third year postgraduate student, you are doing the cases, you are so comfortable in your settings, you know your surgeons, you know how much time they usually take in a normal laparoscopic cases, not in a difficult one I'm talking about. When you see those cases, you know this much time will be taken by the surgeon. And I think many surgeons at many places, they do the laparoscopic chole in 15 to 20 minutes also. Some take 30 minutes. I think using of the supraglottic airway devices is very much valid there. But in any long case surgery, when they're positioning something, the patient position is changed, sometimes you have to remove so many endobronchial intubation. I think all the questions, if you take into account, then in a long surgery, it's better to go for the endotracheal intubation, but you should be knowing your surgical team also very well. There was another question about that putting up the post-op analgesia thing. But just
so as Dr. Bajwa and Dr. Manisha has already said, patient selection is very important.
Let me complete the first part. There was, I forgot to mention at that time. Post-op analgesia, they want to just insufflate both with the local anesthetics. But again, coming to the surgical teams, efficiency, the competency, the tissue manipulation, the tissue handling during surgery, that's very important. You take into account the surgery is prolonged, the tissue handling is sometimes very robust, sometimes very aggressive. In these cases, you require a more of a post-operative analgesia as well as the post-op emesis protection prophylaxis. So in these patients, you have to go with the aggressive treatment of the analgesia, because the first 6 hours are going to be like a hell for a patient who has undergone these type of tissue manipulation during surgery. So it's equally important you see your surgical teams also, rather than just going with the anesthetic management of a case of a lab chole. So that's my take. In any such cases, you adhere to whatever is being given, and at least a senior should always be there to help you out. If you have doubt, always ask your seniors what is the next step to go about. If the surgery takes a longer time, there is a lot of tissue handling also, and in the rest of the concerned airway thing which we discussed just now. Shrutika, any more question? Unmute.
No, sir, I guess there aren't any other questions.
Dr. Mohan Pathak.
Am I audible, sir?
Yeah,
Hello.
audible.
Sir,
Yes, sir.
even the patient is NBM, there is the gastric secretions continue to be there, 50 to 60 ml per hour. And if there is any delay while starting the case, those fluid can always regurgitation. The best way, I think, it will be endotracheal intubation only when the pneumoperitoneal and abdominal surgery. And secondly, while sending home after such big surgery, the patient should be taken in the morning as the first case. How many hours you need post-op observation? All that is important when you say it is a daycare surgery.
Yeah, so that again depends upon the duration, the handling of the surgical field by the surgeons, as well as the type of anesthetic drugs used in these cases, how your recovery is faring. I think majority of the centers now they are doing on the daycare surgery, considering the eras. Then I think it's in the private sector also, sir. We have seen the patient being managed in a daycare basis. But ideally for a institution, it's always better to keep these patients overnight because many
Yes.
complications are there. We have seen if you give the observational data, if you have got many complications can come in the evening or night. At home, nobody is
Yes.
going to manage those complications. Keep these patient at the institution or a hospital even and discharge them the next day. That is also in IRAS. That's a step of IRAS. Keeping a patient at hospital is not something which is going against the daycare surgical principles. But keeping a patient there is a safety factor for the surgeon, for the anesthesiologist, because the first 6 to 24 hours, they belong to both of them. They are common hours. So any complication arising from that time is always better that we should manage them at a place where we have got all the resources and manpower.
Yeah.
Before somebody asks any other questions, I can do a little. Just wait, sir. Kritika, in the meanwhile, just go through the chat box if something is there.
Yes, sir. On it, but I am not able to find anything. Nobody has asked any other question.
Okay, okay. Then let me do my procedure. My screen is visible.
Yes, sir.
Yes,
Yeah.
sir. It is.
So I'm really thankful to the team of MMC led by Dr. Manisha Agarwal, madam. I think this case may look simple, but in reality, these are the cases which are done throughout the country, almost one case per institute every day, minimum. So that is a minimal average I'm talking about. So these are very common cases, but as Dr. Amit and Dr. Manisha madam had discussed during the presentation, there are a lot of complications can happen. Knowledge is a very much essential rather than just going with it's a very simple case, nothing is going to happen. So I'm really thankful to Team MMC led by Dr. Manisha ma'am.
Thank you. Thank you so much. It
ISA
was a
National.
pleasure and a very good learning experience for me also.
Then Dr. Amit, my friend, he always comes up with a very enthusiastic approach and doing the administrative work of ISA and academics is always a boon for our fraternity. Thank you, Amit, for being a part of this teaching program.
Thank you so much for the opportunity, sir, and it's our pleasure.
Yeah. And Lal Tendu Das, well prepared PG student, and I give that credit to Dr. Manisha and Dr. Amit for preparing them so well, and Dr. Mega. Lord Lal Tendu and Dr. Mega, we are thankful for. I think you have done well, and I think Dr. Manisha has taken this special note that you have performed well this examination, so you will be passing the final examination with the flying colors.
Hopefully, yes.
Hopefully. Yeah, and Dr. Ria and Dr. Shrutika. I'm thankful to both of you as coordinators, the class coordinators, because these classes take a lot of technical, preparation to go forward. So I'm really thankful to both of you to handle this class. So I'm really
Thank you so much, sir. It was such a learning experience.
yeah, it was a delight for me also to have class coordinators like you, and more
Thank you,
importantly,
sir.
the real coordinators for these online classes, Dr. Madhuri, Dr. Nishan, Dr. Ridhima, they are always there to help me out. So I'm thankful to them also. So this is a very, very important part in carrying out these online classes, making them a successful and a very good platform to anybody can ask the questions and these classes are always available on ISA and HQ at YouTube. Later on, you can see the recording. So whatever the thing, if PG is going for the examination, you can have a revision provided you have read your books properly. Because majority of the questions will be asked from the books, not from these classes. These are just as supplementary classes for you. In the meanwhile, Shrutika, any question left? No new
No,
question?
sir.
No. And if I think
No new questions, sir.
last 2 minutes, if anybody wants to add to these type of, you know, Uh, any questions or comments, suggestions from anyone? 2 minutes.
Mohan Pathak, sir, has raised hand.
Sir is a regular in our classes. He's a regular student and he's a very senior person, but a regular student. Sir, please unmute yourself. Mohan sir, unmute yourself. You are muted.
There were no facilities in initial days, so we had to do.
Sir, we are not able to make out what you just said initially. This one was muted.
So
Sir, please
we
start from
can
the beginning.
use
We
general
didn't
anesthesia,
hear
but
the earlier part.
in initial days we had to do another.
Sir, we are not able to hear anything.
Hello.
Yeah, sir,
Now,
please. Now better.
in
Now better.
initial days, we had done so many laparoscopic cholecystectomy, which is not fire nowadays, but we had done with a spinal anesthesia only because there were no facilities in the peripheral place. We never recommend that. Now we have got, as according to you, now we have got better facilities. So it's but this is my experience. With spinal anesthesia and epidural anesthesia, we had to do. And if general anesthesia was not sufficient to maintain the blood pressure rise, we had to combine both with renal anesthesia and general anesthesia in those days. Yeah.
Sir, I think that's fine approach, but considering our post-graduation, the teaching in the post-graduation, once they pass out, when they are senior resident, they are competent enough to carry out anesthesia. I think they can go for all the type of the things because the patient safety is most important. Majority of these people who pass out, when they start practicing, they are individuals. Now they are under guidance, supervision. So whatever is taught to them should be the best. We should give the best education knowledge to them. And when they pass out, I think they are responsible for the patient safety. They know how to go about it. That's why they are given the degrees.
Yes, sir.
License to practice anesthesia. It's up to them.
Lalit, sir. Fully agree.
Yeah. Lalit, sir. Yes, sir.
It should be preferred in obese patient that we have to intubate the patient, and it will not on the LMS.
Yes, sir. It's always a case-to-case basis. Obese also, sir, there are many obesities that different BMI patient come with a different BMI, different risk factors. And as Dr. Manisha said, with the different type of risk factors, with the GERD patient, with the gastroparesis, so many things are also to be considered along-wise. So again, sir, it's on a case-to-case basis. And again, on the surgical team, the time taken, the competency, even in the obese patient, if the surgical team is competent enough, they can do in within half an hour. And if the surgical team is also going to have a learning curve in those patients, they may take 2 to 3 hours also, which is going to be very, very, stormy for the attending anesthesiologist team too. So, sir, all these factors to be taken into account when we are dealing with these patients.
In teaching hospital, sometimes the consultant give chances to the PG student also. That's why.
Yeah, these are the part of our learning, sir. If we don't give them the learning in this way, they will never learn. Keep them giving a very hard rule that you have to intubate the patient every time. They will never know how to put a supraglottic device in such cases. But when the consultant, the seniors are there, that's what I told. So they know the patient safety profile. They know the patient safety factors, the limits to up to what we can go ahead with these devices or with other techniques. So in the presence of supervisor, the senior consultant, it's always better to give them a good learning because I think the learning given in our setups in India is almost 3 to 4 times better than whatever being taught in the Western countries. The amount of data, the type of patients, the non-cooperation of the patients, and sometimes the non-cooperation of surgeons also in the many places, and the duration of surgeons, the competency of surgeons. So many things are to be considered, sir. I think that's the best way of learning. It's always dependent on institution to institution protocols, how the HOD and the professor handle their departments and how they make them learn. So that is a way to go ahead, sir, in these cases.
Yes, sir.
And Lalit sir is always there to help us and guide us, being a force, being a HOD, being a principal of one of the most renowned hospital of the country. So he's always a pleasure to listen to you, sir.
Thank you very much, sir.
Anybody else want to say, or when we have to close it down? So in the end, I have to congratulate the postgraduate students also, Lal Tendu and Meghna. You did a wonderful job.
Thank you, sir.
Dr. Manisha, madam, and Dr. Amit has taken a special note of that, your presentation today. So you have done a good in your internal examination, which then be taken for assessment when you are preparing for the final. So this is your assessment examination today. So I'm really congratulating you both.
Yeah, thank you.
Yeah, Nishant, you want to say something? You're smiling so much. You want to say something?
No, sir. It is always a pleasure to see Monisha ma'am and Amit sir. They've been my favorites for a long time. A wonderful class today
Yeah.
also.
They are not your favorite. They are favorite of everyone, not your favorite.
No, no. I'm really
Yeah.
very thankful for all the appreciation, Dr. Bajwa. I think it was a wonderful session as a team. My special thanks to Shrutika and sorry, the other person who
Ria.
was, yeah,
Ria.
Ria, yeah. And it was my first ISA National online class. I'm really happy to have been a part of this. We also have learned so much from all the questions that the students asked and my senior colleagues, the answers and their perception of various concepts. Thank you so much.
Thank you, ma'am. So I think it's a time to say goodbye. It's almost 8:30. Now time to close. So we always end by saying, long live